I learned something. Okay, the recording is in progress, so I can start. Correct?
Yes, yes.
Yes, I
Perfect.
stopped recording.
So they asked me to, Julian and Samuel asked me to bring a topic, and I decided MARS, metal artifact reduction sequences. Why? Because the word metal is very familiar for me, because since early age, when I broke my elbow at 6 years old, and I put metal pins and screw in my elbow, and I spent the whole summer in the hospital. Thank God they took it out, but for me, it's still a fresh memory. But apart from this metal incident, working in these 10 years in MRI, I saw many colleagues running standard sequences for scanning patients with metal implant. So I think with this presentation, I hope it will increase the awareness when we scan patients with metal implants in terms of safety and in terms of image quality. And the third reason is talking about Mars, is a very practical topic. So it's a topic that I think can improve our clinical practice. And also we're going to talk about MRI physics. So it's always good to do a bit refresh of MRI physics. So let's start. The aims of this presentation is to explain what is a metal artifact and how it appears in the MRI images, to explain how to reduce them, explain the SAR, the specific absorption rate, and at the end I will do some examples that to improve our clinical practice. They helped me because I had some constructive reflection after that, and I hope this will help you as well. So we are getting old. I mean, the population is getting old, so the needs for orthopedic metal implant is increasing, especially joint replacement is increasing. So I'm sure even you scanning every day, you get more and more patients with metal implants. And MRI has become an important tool in the evaluation of postoperative patients with metal implants. Many patients complain about pain around the metal implants, and MRI is essential to evaluate infections, inflammation, abscesses, new formations around the metal implant. However, MRI, as you know, has some limitation. The first limitation is the material of the metal implant. There are three types of material: diamagnetic, paramagnetic, and ferromagnetic. Diamagnetic are material like our tissue, our skin, water, fat, and they resist to the magnetic field, and actually they generate a little magnetic field opposite to the main magnetic field. The paramagnetic implants like titanium or gadolinium, they have mild interaction with the magnetic field, so they generate a mild magnetic field. And ferromagnetic implants, that they have a strong interaction with the main magnetic field, and so they create a large positive magnetic field and strong magnetic susceptibility artifacts. And ferromagnetic implants are cobalt, nickel, iron, and all this material can cause a problem to the MRI images. Then the second limitation is the SAR, is the specific absorption rate. So it's the energy that we give to the patient through the RF pulses. So we need to be very careful because we can cause a damage to the patient and cause some burns. But I will talk later about it. Okay, what is a metal artifact? Metal artifacts are related to susceptibility artifacts. Basically, the magnetic susceptibility is the degree to which a material becomes magnetized when it's placed inside a magnetic field. So metasusceptibility artifacts are caused by different degrees of tissue magnetization. So what happens that the spin of the implants and the spin of a normal tissue, they start to process with different frequencies and different phase. I don't know if you are familiar with the spin that are in phase or out of phase, but spin that are in phase, these are my spins, are in phase when the magnetic vectors are aligned. So they spin at with the same phase. When they have a different phases, the magnetic vectors are not aligned. So they spin in a different way. So what happens? That the resonance of these protons is shift out the bandwidth of the radio frequency pulse. And the result is a spatial misinterpretation of the signal in the frequency encoding direction. Normally, we have artifact in the phase encoding direction, like aliasing artifact, flow artifact, but metal artifact, they go in the frequency encoding direction. So, and there are three types of artifact. The first one is the signal loss. So this black hole. So basically it's an absence of signal in the expected location. Then the second one is the signal pile up, when the signal of a voxel moves to another voxel. So there is this hyper intense signal. And as you can see in the image on the top right, this is this hyper intense signal that is showed by the white arrow. And then the third artifact are the geometric distortions. There are two types of geometric distortions. There is in plane and through plane. In planes are the distortion that happens in the frequency encoding direction. The through plane are the distortion that happens when a tilted slice is excited or acquired. Normally, it happens during the 2D sequences when the slice that is excited, not only that slice have the artifact, but also the slice is nearby. It's very important that you remember this difference, so in plane and through plane, because there are some parameters that just reduce the in plane, some parameters they reduce through plane, and with some techniques we can reduce both. So we can have different strategies to reduce metal artifacts. I divided in three ways. The first one is the MRI hardware. So we need to choose the magnetic field strength, so the scanner that we choose, and the coil that we choose, and also the material of the implant. So as I mentioned before, there is a difference between a paramagnetic implant and ferromagnetic implant. The second one is the MRI software. So in the hardware, the patient we choose this option before scanning the patient. The MRI software when the patient is already in the scanner. So it's very important that we select the correct sequences and the correct parameters. For example, the bandwidth, resolution, select thickness. And the third one, it can be in the MRI software, but I put like as a different option because not all the scanners, they have this techniques. And we have VAT, TEMAC, Maverick, and hybrid approaches. So everything starts from booking, because it's very important that I don't know if all of you, they have a booking team. For example, in my clinic at Alliance, we have the booking team, but it's very important that the booking team speak with the patient, and we, for safety reason, we know the metal implant before the appointment. So gathering comprehensive patient information. So it's important to know the type of the implant, the location of the implant. For example, if there is a knee replacement and we are going to scan a shoulder, we need just to check for MRI safety, but in terms of images is okay. And the documentation of the implant is very important. After that, it's good to communicate with the MRI team about the MRI compatibility. So to check if the implant is MRI safe, MRI conditional, so we can scan it, but in certain conditions, or MRI unsafe. Then it's good to coordinate with the MRI team and choose the scanner, schedule the appropriate equipment and time, because normally MARS protocol, they take longer, and most of the time patients maybe with metal implant, they have less mobility, so it's good to increase the appointment time, and providing instruction to the patient. So advise the patient if they feel like a warm sensation during the scan, to squeeze the buzzer, to squeeze the buzzer and let us know as soon as immediately. So let's go to choose the scanner. Here I put some scanners that we have in my clinic. There is a 0.5 Paramed, 1.5 Siemens Sonata that we don't have anymore, 1.5 Siemens Sola, and 3T Siemens Kyra. Why is important the scanner? From that, we need to start from the alarm frequency. So basically, our protons, hydrogen protons, they have some movements. One is the spin, so they turn around their own axis, and one is precession. So they do, I don't know if you can see it, but they do this movement like this. If you, the Larmor equation say that the precessional frequency of these protons is proportional to the magnetic field. So if we increase the magnetic field, the precession of these protons is much faster. So in terms of imaging and scanning, what happens that with scanner with high magnetic field, we get more signal, so we can get better picture in a shorter time. However, the SAR increase and also the artifact increase. So that's why the artifacts in 3T are more pronounced than 0.5. But obviously, it doesn't depend only from the magnetic field, but also on the scanner. For example, in the middle, we have 1.5 Siemens Sonata and 1.5 Siemens Sola. The Sola has new advanced technique that can reduce metal artifact that Sonata doesn't have. So between the two, I would choose the Sola instead of the Sonata. Then there is not the right and wrong. It depends on the patient, the mobility, if it's claustrophobic. So there are a lot of thoughts that we have to make before choosing the scanner. And also it depends on the metal implant. So in the image at the bottom, we see a metal implant with the top of cobalt chrome, which is ferromagnetic, and the lower part is made in titanium, which is paramagnetic. So they have a different magnetic susceptibility. With low magnetic field, we have, as I said, low SNR and low image resolution. With high magnetic field, we have increased SAR and larger metal artifacts. Also, as I said, the material is important. It's been demonstrated with titanium implants. You can, using advanced technique, the result between 3T and 1.5 is similar. When we scan implants with cobalt chromium, in this case, there is a difference between 3T and 1.5. So in this case, I would go with a 1.5. Nowadays, they are trying to find new types of materials like titanium-free, like in aluminum, carbon fiber, and different materials that will decrease the metal artifact, and maybe in the future we don't have to use all these techniques to reduce this kind of artifacts. This is a nice article that I found on the internet that they scan with a porcine knee, so a knee of a pork with different metal implant with two different magnetic fields with 0.5 Tesla and 3T. And as you can see from the images, in the 0.5, we have less artifact. And even if the SNR is low and the image quality is low, the images at 0.5 Tesla are better than 3T. For example, in the image 1A and 1B, the image 1B is, in my opinion, better than the upper one. Okay, so we select our scanner. Now it's time to decide the different sequences. We have spin echo or turbo spin echo against gradient echo. What is a spin echo sequence? Basically, a spin echo sequence is a standard MRI sequence where there is a 90-degree RF pulse followed by a 180-degree refocusing pulse. Basically, what we do, why we do that? Because our protons now in the normal environment, they have random direction. If we place all these hydrogen protons inside a strong magnetic field that we call bit zero, they align to the strong magnetic field in two ways: parallel direction and anti-parallel direction. The parallel direction is with low energy, anti-parallel is with high energy. We know that the number of parallel protons is higher than anti-parallel protons. So the net magnetization vector is going to be formed by parallel protons, that they have the same direction of the magnetic field. In this moment, they are out of phase. When we send the RF pulse of 90 degrees, they go all of them in phase. We stop the RF pulse and they start to dephase, and they produce an energy that is called feed, free induction decay. This signal is not good enough, so we need to send a refocusing pulse of 180 to put this spin in phase again, and after that, they produce an echo. This echo is kept by the machine, and thanks to the Fourier transform, we create the image. As you can see in this image, this is a spin echo. So there is a 90 degrees and a 180 degree. There is the TR, which is the time between two RF pulses, and the TE, which is the time between one RF pulse and the collection of the signal. A turbo spin echo is like a standard spin echo, but instead of using one 180 refocusing pulse, we use a train of 180 refocusing pulse. This makes the scan faster. In this case, in the image, there are three 180 pulses, and this is called the turbo factor in Siemens, or echo train length. And using that, increasing the turbo factor, normally the sequence is faster, but increasing the turbo factor, the TR increase, because we need to place more 180 refocusing pulses between the 290 RF pulses. And the images become more blurred. During my clinical practice, I heard many people say that increasing the turbo factor reduce the metal artifact. In reality, no. Just changing the turbo factor per se, it doesn't change the metal artifact, but the turbo factor can be used to reduce the acquisition time when we scan, when we use Mars protocol. And normally, the turbo factor for T1 weighted image is around 3.5. This is not just standard, it's just a suggestion. In T2, normally the turbo factor is 17, more than 17, and for STIR, normally use 7, 9 of turbo factor. But why it's faster? Because in the spin echo, basically we acquire one line of K-space for each TR, so for each echo. In the turbo spin echo, each 180 refocusing pulse generates an echo, and every time we acquire a line of the K-space. So in this case, we acquire three lines per TR. This is a diagram of a turbo-spin echo sequence. We can see the slice selection gradient, the phase encoding gradient, and the frequency encoding gradient, called also the readout gradients. Keep in mind this diagram because it's going to be useful when we're going to talk about advanced techniques. This is a T1 turbo-spin echo sequence. As you can see, there is a metal artifact. It's not that pronounced. And when you scan turbo-spin echo or spin echo sequences, I suggest to make the TR shorter. Why? Because if you decrease the TE, the time of echo, the amount of time that you give to the spin to dephase is shorter. So it helps to reduce the metal artifact. Here we go. Here we have the gradient echo. In this case, we don't send a 90-degree RF pulse, but in the gradient echo sequences, we send RF pulse less than 90 degree. In the when I said when we send a 90-degree RF pulse, all the protons go from out of phase to in phase. Technically, in reality, it's not correct because there is an effect that is called T2 star. What is T2 star? Is the phase of the spin that is caused by the inhomogeneities of the magnetic field and also from the magnetic field of each spin. So not all the protons after the RF pulse that are in phase. And this T2 star is more pronounced in the gradient echo. That's why they're also called T2 star. As you can see from in the diagram, there is no refocusing pulse, but the echo is produced in this case. There are many types of gradient echo, but in this case, it's caused by the readout gradients that is used in two different, with the same intensity as you can see from the image, but two different directions, and it produces an echo. In the gradient echo, as I said, we don't have the refocusing pulse, and so there is a rapid dephasing of the spin that causes a huge artifact. So my suggestion is, my advice, sorry, is not to use the gradient echo in general, but use all the spin echo and turbo spin echo. Not every time, for example, in cardiac scans, normally in the cine, we use the steady state free precession sequences, the true FISP. But in case of metal, we use gradient echo sequence that are called flash, fast low angle shot. They use a low flip angle that is less sensitive to metal artifacts. So in that case, we will use gradient echo. 1 second, that I'm gonna just drink a glass of water.
I want to take a moment to congratulate you, Manuel, because delivering a presentation in a language that usually we're not used to speak, like from the country we came from, is very challenging. So drink all the water that you want, take all the breaks that you need.
No, it's fine. I was just a bit disagreeing.
Don't worry. Take all the time you need. And congratulations again. You're going very, very
Thank
well,
you.
very smoothly.
I hope you're enjoying it, and if you want me to go faster or slower, just let me know. Okay, fat suppression technique. Steer against fat sat sequences. We have inversion recovery sequences. In this case, what is an inversion recovery is a turbo spin echo sequence, but instead of starting of a 90-degree RF pulse, we start with a 180 refocusing pulse. So we wait a certain amount of time that the tissue we want to suppress is at 0, and we wait for this time that is called TI, and then we start with the 90-degree RF pulse. In the STIR, short tau inversion recovery, normally the inversion time at 1.5 Tesla, it's 150 milliseconds. For the Larmor frequency equation, if you use 3 Tesla, the TI is higher. It's around 230, I guess. And these techniques are very good when we scan metal implants. The FATSAT, they use RF pulse as a saturation pulse that goes to the spectrum of fat in a selective way. In this case, we can see a spur sequence. So it's a sequence that still have an inversion pulse of 180 degrees, but also there is a spoiler gradient that send this radio frequency pulse to to suppress the fat in a selective way. In the stir sequences, there is low SNR, but they are much more robust when we talk about metal artifact, and they are more independent from bit 0 and B1. On the other hand, the FATSAT, they are quite sensitive to the inhomogeneities of the magnetic field. And here we go. We have on the left image a stir sequence, and on the right there is the FATSAT. As you can see, the artifact in the FATSAT is much more pronounced than the stir. The problem of the stir that we cannot use them post-contrast, because in the stir we don't suppress just the fat, but we suppress all the tissue that they have that specific inversion time. So post-contrast, if the lesion that we want to scan gets that inversion time, we are going to suppress it. So we cannot use the stirs after the contrast injection. A good alternative can be Dixon. Dixon use a technique that we can use the different frequencies from fat and water, and in the same sequence we can produce two types of images. And I think in terms of sensibility to the magnetic field is in the middle, but actually is a very good option because the SNR is quite good, and also we can use the Dixon post-contrast. So as you can see from the image, the A and B is a Dixon image, and the C is a FATSAT. So you can see that the first two images the image quality is much better compared to the C. So MRI software and parameters, where we should start? We start with the main parameter for when we talk about Mars, and it's the bandwidth. Bandwidth basically is the range of frequencies that we send or we receive from the scanner, and is the normally we cannot change. We don't touch the transmit bandwidth, but the option that we have in our scanner is the receiver bandwidth, and the receiver bandwidth is the range of frequency that are sampled during the readout. Using higher bandwidth means stronger gradients. So it means that we give more frequencies per pixel. So we reduce the signal misregistration in the frequency encoding direction. Using a strong bandwidth is very good. Normally, the bandwidth that we use for a Spin-Echo, turbo Spin-Echo sequence is around 130 to 170 Hz per pixel. When we scan patients with metal implants, we can increase the bandwidth up to 500, 800, and that can significantly reduce the metal artifact. However, if we increase the bandwidth, the images are more blurred and the SNR goes down. So we need to be very careful when we change this parameter. Normally, the bandwidth for Siemens is calculated like Hertz divided per pixel. in G is expressed as the total bandwidth across the readout direction, and normally is around 8, well, 8 is quite low, 864 kilohertz. And for Philips is expressed as a water and fat shift value. And this one is very similar to Siemens than G. Here we go. We have 3 images with 3 different receiver bandwidth. I scanned this patient. So in the image A, you can see the distortions and the signal pile up. You can see like when you increase the bandwidth, how in the image C, the signal pile up basically completely disappear, and also the distortion are less pronounced. Of course, we get the signal loss, but we cannot avoid that. Another way to decrease the metal artifact is to increase the matrix. Increasing the matrix size results in a smaller encode voxel size, and this reduces the in-plane distortions. So both bandwidth, that is in the frequency encoding direction, and both the matrix, they reduce the in-plane distortions. If you have to increase the matrix, I suggest to increase it in the frequency encoding direction. Normally, when I change the parameters, normally increasing the matrix is the last choice, because all the parameters that you increase, they drop the SNR. So we need to be very careful when we change this kind of parameters. Another one is the slice thickness, and reducing the slice thickness decrease the through plane distortions. And reducing the slice thickness, it use a stronger slide selection gradient. And however, if you decrease the slide thickness, you also decrease the SNR. Normally, it's good to use 3-4 millimeters of slide thickness in the clinical practice. And one thing that we can do actually is the most simple one, is just to change the phase encoding and the frequency encoding. So if there is an artifact and it goes in the area that we want to scan, we can just change the phase encoding. And as you can see from the image, that I took it from Bach, thanks to Bach. That's why it's not in English, but however, the image is clear. So if you change the phase direction, there are 2 different, the distortion is different. So in this case, I would choose the first image. Okay, advanced MRI techniques. We have VAT, CEMAC, and MAVRIC. The VAT is the view angle tilting. The VAT technique is a technique that involves acquire MRI images using a gradient in the slide select direction, and we applying it during the readout. By tilting the acquisition angle, the artifact caused by the metal implant can move away from the region of interest. So that improves the visualization of the anatomy and reduce the distortions in the in-plane direction. As you can see in the image from the top, we have a circle, the original shape. After the metal artifact, there is a distortion, so it becomes like an oval. And if we don't change, if we don't use a VAT, or like if we don't change the parameters, we can see the distortion again as an oval. But if we change the way we look at the shape and the object, we can see a circle again. I hope this image is quite clear. So the VAT corrects the in-plane distortion. If you use VAT, it doesn't increase the scan time, but it makes the images more blurred, and it doesn't correct through plane artifact. Normally, when you use a VAT, you can select the percentage. It goes from 0 to 100. Normally, for paramagnetic for paramagnetic implants, I use around 40–60%. If you scan ferromagnetic implants, you need to increase the percentage. Another technique is called CMAC, slice encoding for metal artifact correction. In this case, we use an additional phase encoding step that we apply always in the slice select direction. And then there is a software that corrects the artifact and create the image. Basically, CMAC use additional phase encoding spatial bins. CMAC is very good because correct in-plane and through-plane distortions. CMAC increase significantly the scan time. So I suggest to use the compression sensing that can decrease the scan time. It works in combination with VAT. So you can use CMAC only if you use VAT at the 100%. And it's based in a T2 turbospin echo sequence. So for every single RF pulse, we excite just one slice. And doing that, we correct the in-plane distortions. But during this acquisition, we don't acquire just a slice, but we cover a volume. And this covering this volume, and then thanks to the reconstruction of the software, we can reduce the true plane distortions. This is the diagram about CMAC and VAT. If you remember the standard turbo spin echo, using the VAT, you can see from the blue arrow, we apply this gradient during the slice selection, during the readout. In the CMAC, we use a slice space encoding gradient. This is just some recommendation from the literature. So for implants with low magnetic susceptibility, it's recommended to use 10 CMAC bins. With cobalt, we go to 1521. In T2 weighted images, so 11 CMAC bins, and for 31, 19 CMAC bins. Remember, if you increase the CMAC bins, the acquisition time increases. So we need to be very careful about that. So in the images on the top, you can see how using different techniques can improve a lot the image quality. So at the beginning, we have a receiver bandwidth that is 150 Hz per pixel, but we don't use VAT and we don't use CMAC. So we can see the pile-up artifact, we can see the distortions. Then we increase the bandwidth, we apply the VAT, and we apply the CMAC. And as you can see, the difference between the image E and the image A. And in the lower image, we have all the bins with different phases that are reconstructed by the software, and then we get the final image after the composition of the algorithm. Then we have the Maverick. Maverick used a 3D acquisition this time. So the CMAC was a 2D acquisition. Maverick is a 3D acquisition technique with a spatial and not selective excitation, which perform phase encodings along 2 dimensions with reduced distortions. Basically, in this case, we capture multiple frequency bands that are called spectral bins to cover a wide range of signal shift caused by the metal implant. These bins then are combined through an algorithm into a final image. Maverick is good because correct in-plane artifact and through-plane distortions. Again, it increased significantly the scan time. So again, use the compress sensing if you have it, of course. Use frequency encoding spectral bins. And disadvantage is that there is an aliasing of through plane direction. especially for hip and shoulder joints. So it's very easy to get a wrap artifact, basically. So in this case, we need to increase the oversampling. Recommendation from the literature. So in practical work, it's good to use 6 Maverick beams for paramagnetic implants, 24 Maverick beams for cobalt, 5741, 81242, and 812 for stir. In this image, you can see the metal implant in the image A and 𝐶mac and Maverick compared to each other. And it's been demonstrated from this article that the Maverick has less pile-up artifact compared to the 𝐶mac. Again, in Maverick, if you increase the beams, you increase the acquisition time. So we need to be very careful. And then at the end, there are some hybrid techniques. There is the off-resonance suppressions, ORS. In this case, ORS works by using different RF bandwidths and different gradients for excitation and refocusing pulses. So only the spins within both ranges are included in the image. This helps to reduce aliasing and scan time. However, it causes signal voice and loss of image uniformity. Then we have Maverick SL with a technique that combines slice direction phase encoding of 𝐶mac with increased spectral coverage. And then there is the combination of compressed sensing and 𝐶mac that reduce significantly the scan time, the 50–60%, and so the acquisition time is around 5–6 minutes. So different brands and different manufacturer, they have different sequences and protocol. GE has Maverick and Maverick SL. Philips, they have Omar and Omar XD, but that personally I never use it. Hitachi has HIMAR, and Siemens has Warp or Advanced Warp. So let's talk now about the SAR, which is the specific absorption rate. As I said before, it's the energy that we give to the patient through the RF pulses. It's the absorbed power divided by the divided per mass. So it's calculated watt divided per kilogram. So when we scan patient with metal implants, we need to be very careful. So I recommend to stay in the normal level and not to go to the first level. There are different ways to decrease the SAR. One way is to decrease the flip angle. So we can decrease the energy of the RF pulse. Another one is to increase the TR. And another one is to decrease the number of slices. Safety first. I just put these 2 examples that happened to me and to my colleagues. In the lower image, we had a patient that came for a cardiac scan, and he brought this X-ray with this metal implant on the right side of the hip. He didn't know because he didn't have any surgery, any operation. We didn't have any information about that. And after that, we got more information, and it was a clip after a colonoscopy. So it was safe to scan, but we have to rebook the appointment. And the upper one, it was an interesting case. It was a patient that came for an MRI of the cervical spine. He didn't have any operation. Actually, he had just an operation of the left wrist. We did the localizer, and we saw this huge metal artifact. So we tried to talk through the speaker if he had any operation. He said no. So we went inside the scan room. We took the patient out very slowly. We checked if the patient had hearing aids or piercing, and he didn't have anything. So he went outside the scan room, and After 5 minutes, he told us that he was stabbed in the neck and in the head. And he didn't remember if he had an operation, things that he didn't mention, so we didn't proceed with the scan. So we need to be very careful when we scan a metal implant, because the problem of the SAR, if the SAR is too high, we can cause burn to the patient. So we need to, as I said, we need to be careful. Okay, case study 1. There was a patient that came for an MRI of the brain. He had a hydrocephalus shunt that was MRI conditional. We did the localizer, and we did the first sequence that was an axial T2 weighted image. And as you can see, there is a strong lack of signal. The person that was scanning thought that was the metal artifact that caused that image, but the problem was caused by the spine coil that was not connected. So after we connect the spine coil, we get the artifact, but as you can see, the image quality is improved. So basically, in that case, the problem was not the implant, but was the coil. So it's not always the metal implant that causes this lack of signal. Another one that many times we get the sequences with the MRI protocol, and sometimes patients come with for MRI knee, and the protocol is vetted with axial gradient echo or FATSAT. I recommend to use STIR instead of FATSAT and to use turbospin echo instead of gradient echo. And it's very important that you write a note in your system saying that you perform different sequences due to the metal artifact. So it's always good to you keep record of why you use different sequences. Here we are, if we are scanning, for example, a different hip, the left hip, you don't have to, if you are scanning just a single hip, you don't have to use Mars sequences, but you can use the standard one. And in case you scan a pelvis with a double hip replacement, you need to be very careful, because the presence of bilateral hip implants appears and increase the risk of discomfort and the risk of burns. Actually, we talked in the safety WhatsApp group about that, and if you have to choose the scanner, go for 1.5 instead of 3T. Okay, this is just an example how to build a Mars protocol. It's not the rule, but just to show you the way I think. So we start, this is a T2 weighted sequence. As you can see, there is ITR and ITE. The first thing that I would do is to increase the receiver bandwidth. In this sequence is 197, so I increase it to 500. But you can see when you increase the bandwidth, the relative SNR goes down. So it was 1 and now it goes to 0.63. Another thing that we can do is to apply the warp. And let's say it's a paramagnetic implant, so I would use the watt at 60%. In case it's ferromagnetic, I'm gonna use CEMAC, so I'm gonna increase it at 100. And just to show you, if you use CEMAC and you put 32 beans, as you can see, the acquisition time is 53 minutes. So you need to be very careful when you use this parameter. In this case, I'm using 10 CEMAC beans and without the compress sensing, so it's 16 minutes. So let's say you don't have compress sensing, so we can make other changes. For example, we can decrease the slag thickness. We can make the images more resoluted, so we can decrease the FOV. But remember, if you decrease the FOV, also you decrease the SNR. Another thing that we can do to make the scan faster is to use grappa. And about the base and phase resolution, as I said, it really depends on the clinical indication. In this case, the signal is 0.59, so 0.59. So I would decrease a bit the resolution to give more signal to the image. So I move to 320 to 70, but again, it depends on the scan that you're doing and depends on the clinical indication. And we can change the phase encoding, and we can also increase the averages to give more signal. This is just an image that shows when we use parallel imaging, you need to be very careful, because if you increase the iPad from 2 to 6, as you can see, the SNR goes down and the images are more grainy. Or otherwise, instead of doing all this, just take a Mars protocol, which is much faster. So this is just a summary of this presentation. We talked about the MRI hardware, the type of the implant and the scanner. The software used turbospin echo instead of gradient echo, use TIR instead of FATSAT. Dixon can be a good alternative. Increase the receiver bandwidth, increase the metric and the slice thickness, change the phase encoding if needed, use parallel imaging, or use advanced technique like VAT, CEMAC, Maverick, or hybrid techniques. This is just the references. I suggest to read the first 4 articles that are very interesting. Also, if you want more information about fat saturation, there is a nice video from Julian about the fat saturation techniques. And that's it. I hope you like this presentation. So feel free to give me some good or constructive feedback. If you didn't like, please send a message to Julian or to someone, not to me, because I'm going to the Philippines and soon I don't want to think about it.
Okay, I will make sure no one will send you any message. Okay, I'm gonna block them. Anyway, yeah, congratulations, Manu. Again,
Thank you.
I want to reiterate the fact that we're here in a worldwide group, and not for all of us, English is the very first language. So having the courage and also the commitment to try to share some type of knowledge about MRI and on quite an advanced topic, I have to say, and also do it on a language which normally is not the one that you speak. The one that you born in speaking, I would say, is even more complicated. So I have to say kudos to you for doing that, because it means you are a person that are willing to take up challenges, and I think this something to be proud of. Now,
thank you, and sorry if I made some mistakes.
No,
but
no,
I hope the presentation
Actually,
was clear. And if you have any question, feel free to.
It was absolutely very clear, and actually, I did really appreciate it, and I learned a lot. Well, I just want to pass the word to Sam for the Q&A. In the meantime, I just want to say thank you for all that are joining the groups on WhatsApp. We have these 2 groups about safety and education. You can find the link on the chat. There have been already some very interesting discussions about MRI safety and also about MRI optimization. Sam, do you want to kick in? Do you want to?
Absolutely. First of all, I just want to thank Manuel for being here today with us and doing an amazing presentation. Manuel, I'm one of those guys that every time you speak about an implant, when I was learning MRI, for me was change the bandwidth. That's it. I didn't know anything else. So I've learned a lot today. And I think a lot of people that joined us also have learned a lot of things from you. And thank you so much for being
You're welcome.
People for an hour, talking nonstop. I know it's not easy, but you
I don't know for how long I talk. It's 9 o'clock.
Manuel, can I just ask you to stop sharing the screen, because I think some might have just.
I'll share it later. I'll share a little bit later.
Okay, fine.
Now, so I will do a quick Q&A. I have one question or two, but I know there's some people that made some questions on the box. So normally the way we do this with the webinars is we get the questions on the box and me and Julian ask the questions. we're going to change this a little bit, and I hope people are comfortable with that, because we want to foster a place where everyone can talk and where we can discuss this topic. So I have a question from Alessandro Mazzola. Alessandro, I don't know if you can unmute yourself, but if you can, would you like to ask your question to Manuel yourself? I can actually try to unmute you. Can you try now? I think you're on mute now. Alessandro, do you want to ask your question? Well, the microphone seems to be on, but I can't hear anything.
That's fine. I think we can just read the question.
I'll read the question. Okay. So Alessandro said the class is amazing. I have a question. What kind of implant is ferromagnetic? Or Manuel is talking about different levels of suitability. Implants more paramagnetic than others to change from VAT to CMAC.
Okay. Implants that are ferromagnetic are like implants with iron, cobalt, nickel, and you can see that the susceptibility, artifacts are much more pronounced with this kind of implants. There is not a rule that for paramagnetic use VAT and ferromagnetic use CMAC. Normally, normally when we look at the localizer and we run the first sequence and we see that there is a huge distortion, and we need to differentiate the in-plane distortion and through-plane distortion. And we see there is the signal pile up, and if we increase the bandwidth and the VAT, we still have this kind of distortion, we need to use CMAC. Remember that VAT only corrects in-plane distortions. If we want to correct the through-planes distortion, we have to use or CMAC or Maverick. So it depends also on the clinical indication. If the artifact goes around the area that you are studying.
Can I add just something on top of this, Manu? I think what you said is perfectly fitting the conversation. I just want to say probably one of the drawbacks that I can think about of CMAC is actually the scanning time, because what you said is completely true. It reduced the through plane and the plane distortions, but the scan time can be raised drastically, and that's why I can see that those that are actually benefit from CMAC are those that have also kind of like AI packages, like deep resolve for Siemens, because in that way you kind of like with an AI algorithm you can speed up the scan time and you can compensate for the fact that you have CMAC on. But without AI, to be honest, I saw sequences that can easily reach like the 7-8 minutes, which will be fantastic. You will see the profile of the implant perfectly, but the scan time can quite become a massive problem.
But in fact, when I can put again the image, like if you increase the CMAC phase encoding bins, without the deep resolve or the compress sensing, the sequence is like 15 minutes with 10 CMAC bins. I don't know if, let me, here we go. See, here we have VAT 100%, CMAC 10 phase encoding bins, and the acquisition time is 16 minutes. So we need to be very careful. I mean, we have to have this option in our scanner to decrease the acquisition time. And compress sensing decrease the acquisition time from 50-60%.
Wonderful. Well, everything in MR is about compromise, right? So we cut corners somewhere to be able to make it quick. There's a few more questions. Before that, Alessandro is doing exams. That's why he didn't manage to ask the questions. He just wrote on the chat as well. There was a question from Patricia. Patricia Morgan, I'm gonna unmute you if you can. Do you want to ask your question?
Hi, Patricia.
Ciao.
Ciao.
So my question was about flip angle. I I can't remember where, but I was taught always that you could always reduce the flip angle to, in that you can hopefully reduce the heating effect by reducing the flip angle. What were your thoughts on that?
No, I definitely agree about that. As I said, the way to reduce the SAR, so the way to reduce the heat that you give to the patient is to reduce the flip angle. Because if we use an RF pulse of 90 degrees, you give a certain amount of energy. If you, let's say a turbospin echo, if you give an RF focusing pulse of 180, you give a lot of energy. If you give a RF pulse of 120, so flip angle of 120, you give less energy, so the SAR is reduced. So yeah, reducing the flip angle is a technique to reduce the SAR.
Well, I hope that answered your question, Patricia. We're moving now to Andrea DB. Andrea, I'm going to give you the
Hi, Andrea.
To ask your question, if that's okay, Andrea. We'll give just a few more seconds, otherwise we'll ask the question ourselves. Okay, so I think the question was, what is the difference between in-plane and through-plane distortion? Okay.
The in-plane distortions are the distortion that happens in the frequency encoding direction. The through-plane distortions are the artifact that happens when you scan a 2D sequence, for example, a turbospin echo sequence, you have 15 slices. The slice that has the metal inside, you don't get the artifact only in that slice, but also in the slices nearby. This is called through plane artifact also, or potato chip artifact. This is another way, funny way to call it. But this through plane artifact, this is the difference. So if you want to decrease, the in-plane distortions, you have to or increase the bandwidth, the receiver bandwidth, or you increase the matrix, or use VAT. If you want to correct the through plane distortions, you have to decrease the slice thickness, or you need to use CMAC, or you need to use Maverick.
Thank you, Manuel.
Yeah.
Appreciate. Sorry, you're going to say something else? Please go ahead.
So through plane distortions basically is when a tilted slice is excited or acquired. This is the definition.
Perfect. I like the potato chip analogy. I think it's easy to remember. So we have a question from Santiago Olaran. Santiago.
Hi, Santiago.
I'll try to unmute you. Do you want to ask your question?
Hi, good afternoon. Thank you. Excellent class, Manuel. I like it.
Thank you. Thank you so much.
You're welcome. No, just I want to know, when some patients have this prosthesis in the knee, and this prosthesis is completely in the femur and the tibia, if you use something special, or these patients move for another exam, for another study? Because sometimes this artifact is so big, it's very hard to follow out this artifact.
Okay. First of all, for MRI safety, you need to check if that implant is a MRI safe, MRI conditional, or MRI unsafe. But most of the orthopedic implants, let's say, that are MRI conditional. Then it depends on the scanner that you have. Because as I said, the magnetic field matters. So the artifact in the 0.5 Tesla are less than 3 Tesla. Then it depends on the software and the techniques that you have. And also, last but not least, it depends on the clinical indication. It depends why they ask for that scan. If they want to check around the metal implant if there is an inflammation, or if there is a different clinical indication. Personally, with the scanner that we have in my clinic, I would scan the patient because I think that I can get good images and I can check if there is an inflammation, infection or an abscess or synovitis around the metal implant. But obviously, it's good that you talked with your radiologist, and communication between the team is very important to take the best decision for the patient.
Wonderful question and advice. We have a few more questions. We would run at least, I would say, 9:30, so it's not too late for everyone. So we have around 15 minutes to do the rest of the questions. So one of our other members of the Fourier crew, Luis Sandia, he has a
Hola,
question.
Luis.
Luis, do you want to unmute yourself, please? I hope Luis is still on the call. Let me see if he's... Okay, I don't think he's able to put his mic on, so I'll ask the question. He's basically saying, do you recommend using mrisafety.com as a support guide in cases of presence of surgical elements? Or is there any other website I can consult in case of doubts? What are your suggestions, Manuel? Do you have any site that you'd like to go?
They put it in our local policies. So in our local policy, it's written that we need to rely on that website. So my answer is yes at the moment. Then if I change company, I will let you know. But at the moment,
I think this is a completely different word, right, Manuel? A completely new discussion.
So I think that Samuel has better knowledge about MRI safety. And I know even in the podcast, you interview different people. So what do you think, Samuel, about MRI safety?
You said I'm going to be unbiased here and say that follow your hospital policies as much as you can. They're national, international guidelines. If you want to go to the internet and look for stuff, I would go straight to the manufacturers to see their conditions for the implants. Of course, you can go to these websites. They are reliable sources, but they are not always updated. Of course, there's new things coming out like Nordinsight. They are partners of Everything MRI as well. They have this database. They use AI to search implants. So there's loads of materials out there that you can use. I wouldn't focus on one source of information. And if you have to base yourself in one source of information, I would base myself on the national guidelines of your country. That would make it easier. So just to be unbiased, of course. I'll give word to Daniele Silipu. I hope I'm not butchering. Daniele, do you want to...
Can you hear me?
Question?
Yes, I can hear you, Daniele.
Hello, Manuel. First of all, I'd like to thank you for the great presentation. It was on spot.
Thank you.
My question is about cardiac MRI. I would like to know if there's any useful technique to reduce metal artifact in the context of CMR, considering that is often a challenging part of MRI and where timing is quite crucial. So I would like to know your opinion about this topic.
Yeah, of course.
Before you answer that, since we're talking about cardiac, I'm just going to put a slide on the screen and then you can answer.
Do you want me to end the presentation?
Don't worry, I'll do it. You can answer the question. That's fine.
Okay. As I said, Daniele, in my presentation, turbospin echo and spin echo are better than gradient echo. When we scan cardiac examination, normally in the cine, we use the true FISP, so the steady state free precession. But in case we have patients with cardiac pacemaker, that is MRI condition, and it's okay, and we get the artifact, I suggest to use the flash. The flash are a gradient echo, are fast, low angle shot with that they have a very small flip angle that make this sequence less susceptible to this kind of artifacts. So my answer is use flash instead of steady state free precession.
Wonderful, Manuel. We have a question from Carla Morim. I suspect she's Portuguese from the name.
Yeah, I know her. Hi, Carla.
Carla, would you like to ask your question, please? I think I gave you permission to unmute yourself, so just let me know if you can do it. Otherwise, I'll ask the question myself.
I'm happy. to see you.
I don't think I'm able to put the mic on, so I'll ask the question that she had. If not mistaken, you mentioned we should increase the slice thickness to reduce the artifact, but now for the true plane, you mentioned to reduce it. Can you clarify?
No, sorry, maybe it was a mistake. If you decrease the slice thickness, you reduce the true plane artifact. Maybe I mentioned by mistake, but it's good to decrease the slice thickness. Just keep in mind, if you decrease the slice thickness, you also decrease the SNR. So you need to, the images, you get more grainy images. So you need to compensate that with other parameters. But yeah, my recommendation is to use 4 millimeters. Well, depends on the clinical indication. But if you decrease the slice thickness, you decrease the true plane distortions.
Wonderful. I have John now, John 𝐿𝐼. Sorry, I might be butchering your name as well. I apologize.
Hi, John.
John, are you able to put your mic on? There you go.
Yes, good evening, everyone. First of all, I would like to congratulate Manuel.
Thank you, John.
Well presented presentation, very informative and practical. My question is, because you mentioned activating warp. So when you activate warp and you activate VAT, how much VAT would you apply? And do you have a range of values, and why do you use these values for your procedures?
First of all, thank you. I tried to make a presentation that is practical so it can help us in our clinical practice. I think there is not a standard rule. Basically, we need just to understand the consequences of increasing VAT. Normally, for paramagnetic implants like titanium, I would use 40-60%. In case, sorry, is a ferromagnetic implant, I will increase the VAT to 100% and maybe use CMAC. But just keep in mind, if you increase the VAT, you make the images are more blurred. The acquisition time doesn't change, but the images are more blurred. So you need to be very careful and just remember that the VAT reduces the in-plane distortions. So the answer is 40-60% for titanium, and you increase more in case of for cobalt and other materials.
Perfect. I think we have still a couple of questions. I don't know, Julian, if you have some. I have one question, but I'll ask the next one now. It's from Beatriz Bessa, also from Portugal. So Beatriz,
Hi, Beatriz.
Try to ask your question, please.
The microphone doesn't work today.
Not for everyone. Beatriz, you will try a little bit once more. Do you want to unmute yourself? If not, I'll ask the question. All right. So she says, when you said we should use a larger bandwidth, it causes frequency dispersion and voxel misplacement. Oh, sorry, the question disappeared. But I was wondering if augmenting the necks would help with that.
Definitely, yes. If you increase the bandwidth from 130 megahertz hertz per pixel to 500 hertz per pixel, you have a drop of the SNR. And one of the ways to compensate this SNR is to increase the averages. Remember that when you increase the bandwidth, you can decrease the TR. So the acquisition time, you reduce the acquisition time. And then you can give more signal, maybe increasing the averages, increasing the oversampling. Even if you increase the FOV, you give more signal. So you can use all these techniques to give more signal to the image. But yes, the average is the main one. So perfect. Normally when if I have one average and I increase the bandwidth, I can use 3 averages and use grappa, for example.
Wonderful. I think that was the last question from the chat. I have one question myself is about the increment of low fields everywhere. So we're buying more low field scanners, but at the same time we have higher fields with AI. Where do you see this adoption on both extremes helping artifact? Do you think we're going to have more low field scanners and less artifacts, or actually the higher fields with all the AI and the algorithms that we have that help reduce these artifacts are the way to go? Do you have a personal opinion on that?
Yeah, my answer is it depends on the low field. For example, the scanner that we have is an open scanner 0.5 paramet, but there are no parameters for metal reduction. I don't even have the bandwidth. So the only thing that I can use in that scanner is the magnetic field per se and reduce the TE. It's the only two parameters that I can use to decrease the artifact. If we have the same scanners, for example, in the article that I mentioned, they use a new Siemens 0.5 and a 3 Tesla Siemens. They have a VAT CMAC. So in that case, I would go with the 0.5 instead of 3T. Then also, the new implants is gonna help a lot with that. So different materials will help a lot to reduce the metal artifact, and then it will depend on the implant. But if we have 0.5 and 3T with the same options, advanced technique, I would go for the 0.5, to be honest, in terms of safety, but also in terms of image quality, because the main point is to make the image diagnostic. We don't have to get high resolution images. We need to make the images diagnostic for that specific clinical indication.
Yeah, you have to get an answer with the best that you can, right? With that artifact. As long as you get a diagnosis, that's what matters. Julian, do you have any questions?
Yeah, no, I think it was great, to be honest. I just want to feedback one of the slides Emmanuel provided, which was great. With my personal experience, there was a beautiful slide about a patient having a double hip replacement, saying that we need to be particularly careful. And he also have included the MHRA guidelines. And I have to say, the only burn that I have experienced in my life was on a patient with double hip replacement.
Yeah.
So, and this gives you the idea. I mean, obviously, I'm not exactly new in SVO Mini. I'm not a student, unfortunately. But yeah, in 10 years, I have to say the only burn that I've experienced was because of double hip replacement. So what would be your suggestions about this?
No, it was funny because yesterday in the MRI safety WhatsApp group, one of us mentioned about these burns after a double after scanning a patient with a double hip replacement. Yeah. So you need to consider that the risk of burns are much higher. So we need to use LOSAR and talk to the patient every sequence. It's very important, the communication with the patient, and check the patient every sequence. And also reducing the SAR. So again, reducing the flip angle, using a low magnetic field, increasing the TR and decreasing the number of slices. So helps to reduce the risk of burns, to minimize the risk of burns.
Wonderful. Guys, I think this is the end of it. Just to everyone see it now, I'm sharing on the screen our cardiac course. So if you want to join us, or if you want to learn a little bit more about it, just take a picture of the QR code. We also share the WhatsApp groups that Manuel has been referring to. It's an MRI education one, MRI safety one. So there's two groups where we have radiographers from around the world. We have several countries there. We have presidents of associations, and then we have experts. So everyone is there just sharing stories and sharing questions and doubts. So feel free to join us. Julian, do you have any other things to add? I want to thank personally to Manuel to be here today and do this stellar job. Everyone is saying you're amazing. And
thank you.
On myself, I'm very happy to have you on the Fourier crew. I think it's an honor to have someone like you joining us. So I'll pass the word to Julian. From me, it's all today. Thank you all so much, and keep looking for more events and more content, because we will keep posting things for free for everyone to attend.
Yeah, I don't want to steal any more time, Sam. I think this was a fantastic work from Manuel, but also like a collective work from the Fourier crew. For those that provided,
they helped me with the images and the
for those that
presentation.
have provided images, for those that have provided promotional videos. So I think
yes,
a fantastic joint effort, and but especially to those who attended today, because without you guys, this wouldn't be possible. So thank you for being so active on those WhatsApp groups. Thank you for being so active on our social media platforms and on our YouTube channel as well. And just want to say thank you for being here today.
Thank you.
Thank you.
Nice.
Bye, guys. Ciao.
Bye-bye.